and welcome. Today we are going to talk about how functional exercise can alleviate chronic pain. So whether you're an individual who is suffering from chronic pain and you're seeking alternative therapies, you're a healthcare professional and you're interested in integrating functional movement into your patient care plans, or you are just curious about the scientific foundation of functional medicine and movement, you are in the right place. Hi, my name is Dr. Arianne Missimer. I'm a functional medicine practitioner, doctor of physical therapy, registered dietitian, and owner of the Movement Paradigm Integrative Health Center, and I'm super excited to be on the Rupa University team. And today I'm going to talk to you about one of my favorite topics. I've been helping thousands of people over my entire career improve their functional movement and reduce pain. So this couldn't be a more appropriate topic to dive into. So we're going to talk today a little bit about acute versus chronic pain, some of the predictors of non-contact injuries, how functional exercises can alleviate chronic pain, how we can assess our functional movement, and also really understanding the body's healing process. So why is movement so critical in helping us heal optimally? And of course, we'll bring it all together with sharing a patient case story. So we know that chronic pain is a widespread challenge. Even in my clinic personally, this is the majority of the population that we see that is experiencing so much chronic pain and disability. They have been to so many different practitioners, from physical therapists to chiropractors to other rehabilitation specialists, also have worked with pain management doctors, functional medicine, and so on, and still don't have a cure. So this is where we need to look at it from a really multifactorial perspective, just as we always do through the lens of functional medicine. 1 in 5 adults suffer from chronic pain, according to the CDC. So in 2021, 20.9% of U.S. adults experienced chronic pain, and 6.9% experienced high-impact chronic pain, meaning that it was contributing to disability. It is often associated with sleep disturbances, depression, and fatigue. So this is where we begin to think about mitochondrial dysfunction. Many struggle with finding long-term relief and solutions with conventional treatment. And this is where functional medicine and functional movement can offer a really amazing approach to pain management. I think it's important to understand why people sustain non-contact injuries, because this is often why people are coming into the clinic with chronic pain. They've had chronic low back pain, they've had chronic neck pain, they've had chronic shoulder pain. They don't recall a specific incident that caused it. And this is an example of where previous injury can be a number one predictor of re-injury, and also asymmetries. We know that the human body is asymmetrical in nature. This is because of our organ placement. So our right hemidiaphragm sits higher than our left hemidiaphragm, for example. This can cause very specific patterns in our body of creating subtle rotations. And when we become over-patterned, this can influence our movement patterns. What we're referring to here is that when our movement patterns become asymmetrical, for example, our right shoulder, we're able to easily touch our hand behind our shoulder blade, but on our left side, we're not able to really do that much at all. This could in turn predict a potential injury. I think it's important to discuss the stages of healing, because this is where we can really have the opportunity to use movement to prevent someone moving from acute pain to chronic pain. Let's take the example of an ankle sprain. So we have 4 stages of healing. The first stage is bleeding. So in this short stage, typically under 24 hours, this is where we're focusing on protection and reaction to the initial injury. So we have different cells that are rushing to the area to stop the bleeding. So we have thrombocytes that are going to help from prevention of clots and trigger vasoconstriction. We have platelets that are also going to assist in clot formation. And we also have leukocytes, which are a type of white blood cell that are going to protect against foreign bodies to hopefully protect against any infection. So this is a really important stage where we want to set a solid foundation for the subsequent stages of healing. And we want to make sure we're responding to that initial trauma to reduce any potential complications. The second stage is inflammation. And remember, this is our normal defense and repair mechanism. This is going to focus on protection and early repair, and it does overlap with stage 3. This is when inflammation is present, so typically swelling or bruising, increased temperature. Picture that ankle sprain, that fresh ankle sprain, pain, loss of function at the site of injury. And this is where we have specific chemicals that are released to stimulate the inflammatory process. This is going to create a vasodilation that causes that redness and swelling and everything rushing to the site. This is also when we are activating those pain pathways. So this is often a time where you're starting to get more pain input. And lastly, we have phagocytosis, which is a protective mechanism where the white blood cells are engulfing foreign bodies to prevent infection. This is a stage where we really want to manage inflammation. It's really important. So that could be anything from things like compression, stockings, or movement, and so much more, which we'll get into. And then stage 3 is proliferation. So this is where we are reproducing rapidly. So this is going to be the first of 2 major rebuilding stages. The phagocytes are going to start to leave, and therefore the inflammation starts to reduce a little bit. You start to get a little bit better function. It can start anywhere from 24 to 48 hours after an injury. It can last up to 3 weeks once the bulk of the scar tissue is formed. So we have this fibrin matrix from the bleeding and inflammation, and it's going to be replaced by this immature, disorganized tissue. So I was normally explain it as we normally have these collagen fibers that are nicely aligned. And when we start to form the scar tissue, that we have these crossed links like this. So it's just disorganized and it's immature tissue at this point. That could be bone, muscle, cartilage, etc. And it cannot withstand final forces. So this is where movement's really important, but we don't want to put too much stress on the tissue because it's not ready for it yet. Okay. And then the last stage is the remodeling stage. So this is crucial to allow the immature tissue that was laid down to be now converted to a more mature and even organized, structured matrix. This can be months to years, depending on the injury, depending on the type of tissue. And we're taking this disorganized immature tissue from the proliferation stage and aligning it into this more specific construct final tissue type. And this is where, of course, movement and loading the tissue is extremely important. And now I just want to take a minute or two to talk about pain, because I think this is a really critical part of understanding how we can manage it better through movement. So what is pain? It's defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So what we just spoke about was actual tissue damage. You roll your ankle, you go through those stages of healing, but we also want to recognize that your perception of pain could be that there is no tissue damage at that time, but you are still perceiving pain. And that's where we get into acute and chronic pain. Pain is actually a great thing. It is our alarm system. It is something that is giving us information, and it is a request for change. So when we are thinking about pain specifically, we have something called nociceptors, which are a type of receptor that's actually a sensory nerve, and it's a response to a harmful or painful stimuli. Think of if we put our hand on a stove, we are going to get that immediate feedback to our brain, specifically in this anterior cingulate cortex of the brain, and we are going to have feedback of this emotional experience. So signals are essentially going through the spinal cord and to multiple areas of the brain for us to perceive that information. So we can have lots of different types of pain. We could have muscular myofascial pain, joint pain, bone pain, nervous system-based pain, which think of migraines or neuropathic. We can have neurodegenerative disease. We can have visceral, somatic, so things like IBS and hypersensitivity in the viscera. We can have post-surgical pain, cancer, chemotherapy-induced, emotional, and even more. There's 4 different types of pain. So there's the nociceptor that I just spoke about. So that's that sensory receptor in the peripheral nervous system that's capable of essentially transducing and encoding the stimuli, this painful stimuli. We have hyperalgesia, which is a condition where a person is developing an increased sensitivity to pain. So that might be that they might have an experience with pain, so they might bump their elbow, but they have a really heightened degree of pain, even though there wasn't a lot of trauma to the tissue. Neuropathic pain can be caused by a lesion or disease of the somatosensory nervous system. And then we have allodynia. So this is essentially pain due to a stimulus that does not normally provoke pain. For example, your sheets on your bed, your blankets rubbing up against you, brushing up against your arm. So basically a light touch, for example, can create a significant pain response. And then we have something called sensitization. So this is where we talk about chronic pain. There's an increased responsiveness of nociceptive neurons, so these painful receptors, to their normal input and or recruitment of a response to normally sub-threshold inputs. Basically have this increase in pain and an inability to dampen the pain. So essentially, as it relates to pain science, the brain is giving you a perception of what is happening. This alarm system is going to tell your brain where the pain is in your body, the amount of danger, and the nature of the danger. It could be anything from sharp or burning or aching or tingling or dull. And we want to think about these two distinct types of pain, acute pain versus chronic pain. This is extremely important. Acute pain is our warning signal. It is going to be immediate. It is going to last within 3 months. So when we think about motor control, think of this as defined as sequencing, timing, and coordination. So I spoke earlier about asymmetries, previous injury contributing to non-contact injuries. And when we're thinking about motor control, Hodges has done a great job in the area of motor control. And so as he states, suboptimal movement or motor control can serve as a precursor to injury and pain. But in addition to that, impaired motor control can be a consequence of actual or threatened pain or injury. And then in addition to that, modification of movement or motor control can protect a painful or a threatened area. And modified movement can be explained by a conditioned association with pain. So when we think about what happens normally I can speak to the US specifically, is we have an episode of back pain. We go to the doctor and they say, okay, let me give you some muscle relaxers or let me give you some pain medication to manage this. Then that doesn't work. So then they're referred for an X-ray. X-ray does not show anything. Then they are still having pain. So now we're fast forwarded this process, maybe 2 months, 3 months. And so now they're on the path to potentially getting an injection. No improvement there. And then they are getting an MRI. Then at that point are typically referred to physical therapy or rehab, chiropractic. Then they begin to exercise and then they begin to integrate back into their world. Well, if we were to just stop that path early on, we could make such significant improvements. But what we see is that we start to get these images, and it's important to recognize that these images are not necessarily reliable. So structural abnormalities that are indicated on any diagnostic imaging, especially things like X-rays and MRIs as it relates to musculoskeletal pain, does not accurately assess the extent of one's pain, nor does it provide valuable information about what to change from a movement perspective or make the pain better. So in 2015, there was a systematic review of spinal imaging in pain-free individuals, which indicated that over 80% of those imaged had some form of disc degeneration, although they were pain-free. 2012 study in arthritis demonstrated that X-rays of individuals with knee osteoarthritis were not significantly associated with the severity of their knee pain, stiffness, or disability. There was another study by Gurish et al., and that found that bursal thickening, slap lesions in the shoulder, acromioclavicular joint degeneration, and rotator cuff tendinopathy were in 78, 72, 65, and 39% of pain-free participants, respectively. And then in 2012, there was a prospective study published in the American Journal of Sports Medicine, found up to 73% of hips had abnormalities, although the patients studied had zero symptoms. So it goes to show over and over and over again, and I can speak to this thousands of times over, is that your clinical presentation and pain does not necessarily correlate with your images. So it's really important to know that. So now let's move into why is functional movement so important? What is functional movement? And how can we begin to integrate this into our patient care plans? And if you are listening yourself, how can you begin to move into this path? So think of functional movement as what we are doing in real life. We are pushing and pulling and lifting and carrying. We are doing functional movements that are going to simulate day-to-day real-life activities. This is going to focus on mobility, stability, strength, potentially endurance, speed, power, depending on who you are and what your goals are. And it's emphasizing these natural movements that we were designed to do as infants and that we have began to sometimes lose over time. Things like squatting and lunging and twisting and pushing and pulling, as I mentioned. This is all based on the concept of neurodevelopment. So these are the fundamental activities of the human body that revolve around the most simplest and basic patterns of human movement. And we want to think of this as a developmental sequence that starts at infancy, where we are born with tons of mobility. We're able to put our feet in our mouth, and we're able to curl up into a little tiny ball and sleep in any position. And then we are developing stability or motor control. We're developing that sequencing, timing, coordination. We're beginning to stabilize in different postures, moving from things like rolling and then into sitting and then into crawling and moving in these developmental stages, ultimately to things like deadlifting and deep squatting. Let's dive into stability a bit more, is that oftentimes we think about core regarding strength, but really core is about stability. And when we're talking about not only injury prevention, but how can we address chronic pain through optimal movement, we need to come back to the concept of neurodevelopmental kinesiology and be able to really understand what did we do as infants and how do we lose these patterns over the years. So when we're referring to stability, we want to think about our center of stability as right below our belly button, the level of S1, so our sacrum, so S1. It's the foundation for generating power, force, and resistance. So stabilizers are going to activate before mobilizers. This is where we can break up our musculature of stabilizers into local stabilizers and global stabilizers. This is really important because this is actually what we're focusing on as it relates to optimizing functional movement, improving neuromuscular control, helping to prevent injury, but also helping to rehabilitate from injury or chronic pain. So the local stabilizers, think of these as super close to the joint. They're going to be the diaphragm, the respiratory diaphragm, the pelvic diaphragm. So our pelvic floor, our multifidus, which is right along the spine, our posterior fascicles of our psoas. So this means the back of the psoas actually acts as a deep stabilizer. So we always think of our hip flexors, we have to stretch them because they're tight, but really, in fact, they act as this integrated unit along with the other stabilizers. We also have our transverse abdominis. Think of this as your natural weight belt. Then we have our global stabilizers. So think just outside of these. We have our obliques. We have our spinalis along our spine. We have our glute medius. So oftentimes when we refer to hip stability, we're talking about glute medius, but really there's deeper muscles beyond that. And the anterior psoas, so the front of the psoas. And then we have our global mobilizers. So this can be things like our rectus abdominis or six-pack, our iliocostalis, and our piriformis. So I like to think about our stabilizers of our hip as we have our piriformis, which is often what tends to get tight on many people. We can have presentation of piriformis syndrome that can compress the sciatic nerve. But really, there's muscles deep underneath that. We call those the deep five, and those are stabilizers as well. Those are close to the joint. Those are what really help us to stabilize and create the proper motor control. When we're differentiating these between local and global, again, close to the joint, they create more of an isometric contraction. They are going to control what we refer to as joint centration. So think of the rotator cuff and the shoulder joint. So the rotator cuff is going to allow the shoulder joint to stay in that center axis. So we always talk about strengthening the rotator cuffs, but really they are stabilizers. They are going to have a lot of proprioceptive input to the joint. So they're going to give us a lot of information to our brain about joint position. And then when we refer to our global stabilizers, these are going to actually create a little bit of force. So if we think of that glute medius on the side of our hip, it's going to help to control more eccentrically our hips. So especially with walking and in our mid stance specifically. It decelerates momentum and it has a non-continuous activity versus a activity independent of direction of movement. So that means that when I go to raise my arm overhead, my multifidi in the back is going to stabilize before this even happens. When we have low back pain, especially chronic low back pain, we can see that transverse abdominis isn't firing as quickly. So there's this delayed input. So when we're referring to this integrated stabilization system, we can use something called the stack. And the stack is very simple, and it's a great cue for yourself, for your patients, your clients you're working with, for you if you're watching this, is we want to think about optimizing our respiratory diaphragm over top of the pelvic diaphragm. So if you look at this first picture on the left, you can see that it's beautifully stacked, just like it was when we were newborns. And that allows for the proper communication of the respiratory with pelvic diaphragm. So we can create the appropriate amount of pressure. And if you look at the other pictures, you can see that this structural misalignment is going to lead to poor pressure management and stabilization. So we can call that second posture an open scissors posture, where very, very common. So the rib cage is flared, the pelvis is tipped forward. You can see there will be more compression in the lumbar spine. And this is one of the things that we see when we have, again, this poor integration of deep core stability. And now we know how important this is as it relates to a neurodevelopmental approach to functional movement. This is the foundation. So this is a good visual of this intrinsic stabilizing system of how all of these muscles need to work together. And ultimately, we are doing this by creating this 360-degree pressure. So as we inhale and the diaphragm flattens, what happens is this pressure starts to build up. You could see that both of these pictures. So the pressure is building up, creating 360 degrees of pressure all the way down to the pelvic floor. This is what's allowing this eccentric or lengthening contraction of the transverse abdominis, our natural weight belt. We get this relaxation of the pelvic floor, which is extremely important. And then as we exhale, we get a contraction of the pelvic floor, contraction of the transverse abdominis, and the diaphragm goes back to its resting position. So everything that we think about as it relates to core and stability is actually all about pressure. Especially when we talk about pelvic floor issues, pelvic pain, and so on, we want to be really thinking about pressure specifically. And taking this just a step further, when we're talking about stability, a great way to think of it is that we have to stabilize first. And what we refer to as it relates to this is called a pre-activation stiffness. This means that we are going to have better movement accuracy, better movement efficiency, injury prevention. And the best example I can give is that if we are walking, before your foot even hits the ground, your body, your lower leg is actually creating the stiffness through isometric contractions to stabilize before you strike the ground. If it doesn't do that, then that's when you can have disrupted movement patterns. And the example that I just gave is when I go to raise my arm overhead, my multifidi are activating before that even happens. So this is what we're referring to as this pre-activation stiffness. When we take it into dynamic movement, it's called time to stabilization, so TTS. So neuromuscular control is going to play a huge role in dynamic joint stability and protection against injury. So when we have chronic pain, the way that we move matters, how we move matters, how efficient you are at interacting with ground reaction forces matters. And if it's not well controlled, can contribute to more neuromuscular fatigue, can impair stability and control, thereby creating more injury and potentially more pain. So time to stabilization is a more recent measure of neuromuscular control, and it incorporates the sensory system and also the mechanical system. So when we're thinking about reflexive stabilization, the best way to think about this is through impact force. So we are getting a certain amount, or every time we strike the ground, we are going to create a certain amount of impact force. our fast twitch muscle fibers are going to fire at a rate of about 70 milliseconds. But the information that's coming into our body is coming in at a rate of about 50 milliseconds. We are detecting this force through vibration. So if we are not able to stabilize fast enough and stabilize reflexively, we refer to that as anticipatory stabilization, then we are reacting. And a perfect example of this is something like an ankle sprain. So if you were walking and you step on a curb and roll your ankle, that is a very reactive process. We want to train our body to be preactive so that just because you roll your ankle doesn't mean that you're going to get a significant sprain from that. When we're thinking about how to use energy and how functional movement relates to that, is every time we strike the ground in walking, we're encountering about 1 to 1.5 times our body weight in force. When we are running, we're encountering approximately 3 to 4 times, jumping 10. And when we are, some gymnasts, high-level gymnasts like Simone Biles, for example, can encounter up to 18 times their body weight in force. So when we're talking about movement efficiency and movement accuracy, it's ultimately how are we utilizing this energy? So how are we loading what we refer to as potential energy and then using that as elastic energy? And someone that's experiencing chronic pain, this is extremely important because if we said, okay, we want you to start to walk as a means to get back into movement and exercise, but you or a patient is not moving efficiently, not interacting with the ground well, not stabilizing well, then unfortunately this could lead to more pain and injury and frustration. So it's very, very important to think about stability is the take-home of this, because ultimately improving someone's movement efficiency is going to decrease injury risk, improve their gait, and improve their overall movement and function. As I mentioned, when we are interacting with the ground, we are detecting that information through vibration. So this is where it's really important to think about, let's say, what shoes you're wearing or socks you're wearing. Is someone going barefoot? Is your patient ever barefoot at home? Because we want to reinforce the sensory information that's coming in through the specific mechanoreceptors on the bottom of the feet. That is going to signal to the brain that this is accurate movement. If we are blocking that information with socks and really high cushion shoes, then unfortunately that information is inaccurate, and that can lead to its own poor movement patterns over time. And a great example, I've done so many of these over the years, this is called a K-vest. So this is specifically for golfers, but it's really interesting because if you look at the graph on the left, we're looking at the kinematic sequence of a golfer. And I love to be able to use this as a visual of how we could look at all of our movements, is how well are you sequencing in every movement that you do? And so in this example on the left, this person is not sequencing very well at all. They're initiating the movement with their torso, then their pelvis, and then the club. So of course we want, from a golfer perspective, we want it to be the pelvis and then the torso and then the club. And therefore the peak speeds were off. So distance and accuracy is going to be really off for this person. When we look at the graph on the right, you can see that the sequence is improved. So it's exactly how it should be. The peak sequence is also improved. And then also because of that, the peak speeds are going to be improved because it's a more efficient movement pattern based on the stability and motor control of what's happening. So I love Tom Meyer's work, who is done amazing work in the field of fascial science and fascial anatomy. And so the deep front fascial line is actually part of our deep core. And I'd like you to look at how it initiates from the bottom of the foot and goes all the way up behind the knee to the inner thigh, into the pelvic floor, into the hip stabilizers in the back that I was referring to, into the hip flexors, the diaphragm, all the way up to the neck and even the tongue. So when we begin to improve movement quality over time, we want to think about really integrating the foot all the way up through the core and even the head and neck. And this is just one fascial line of many, but this is a great way to think about how we want to train functional movement is through integrated patterns. And using the fascial anatomy of this 3D network is extremely important. In addition to this, as it relates to pain, is that we have so many thousands of sensory nerves in our fascia. And because of that, the way that we move or not move, so for example, if you're sitting all day because you're in pain, you're not moving, you're not getting out of bed, this is going to have extremely poor feedback to your brain because our brain and our fascia depend on movement. So it depends on movement for hydration and elasticity of the tissue. So it's really important to begin to use this as a way to integrate these together. Now, as it relates to mobility, so mobility is defined as being able to move a body segment pain-free, non-restricted. There are a few tests. There's lots of different tests we can do, but I'd like to just touch on a few. So there was a great study that I'll explain in detail in a moment, which is a sit-to-stand test. And essentially, the lower score you had, you were 7 times more likely to die. So there was an influence on mortality and life expectancy within the next 6 years. There's also the functional movement screen, which is an evidence-based screen that looks at your movement from a quantitative standpoint and be able to measure your movement and also provide a score to note how likely you are to be injured. So why would we even do a movement assessment? So it's really important to do movement assessments and work with a skilled clinician or refer to a clinician who is able to do this, because this really gives us insights into someone's movement patterns and compensatory strategies. This is going to allow you or your patient to be able to move back into the world pain-free, to be able to function at a high level and do it in a safe and graded way. It can help to identify very specific joint stability and joint mobility limitations. It can help to assess movement efficiency that's affecting the entire kinetic chain. It can help to identify weak links in the kinematic sequence, as I talked about. So think of those weak links as an energy lake. So if you envision that golf swing, if you're really unstable through the core and pelvis, that is going to be an energy lake. And so that's going to show up in how efficient that force is transferred. And it can guide the most effective treatment plan as well as injury prevention and also this graded exercise plan. So in a Brazilian study of 2,000 people, the get up, sit down test, where they were asked to get down to the ground, get back up with using as little body parts as possible, what they found is that if they got a score of 0 to 3, they were 6.5 times more likely to die during the course of the study as compared to 8 to 10. If they got 3.5 to 5.5, they were 3.8 times as likely to die as the high scorers. And then 6 to 7.4, they were 1.8 times more likely to die than those with the highest scores. So essentially, this study reinforces that maintaining optimal mobility, stability, coordination, functional strength are not just important for performing daily activities, but also having a favorable impact on life expectancy. So essentially, the more body parts that they used to assist themselves is the more points that were deducted. So essentially, this is a really nice mobility test that we can use. And the functional movement screen is also a great test I used for many, many years with clients, which is a deep squat hurdle, so a squatting pattern, a lunging pattern, a active straight leg raise, which essentially is a hinge pattern, shoulder mobility, trunk stability push-up, and rotary stability. And there's also some pain provocation tests. This is a great way to identify that if you have a score of 14 or lower, you are at greater risk for injury. If you have asymmetries in your movement, you are also at greater risk, as I mentioned earlier. So this can be a really, really great way to utilize as a way to get someone back to functional movement when they are coming from chronic pain. There's a medical version of this, which is the selective functional movement assessment. So I use that regularly as well. And that looks at functional patterns versus dysfunctional patterns, painful patterns versus non-painful patterns. And I think it's important to touch on pain and fear avoidance. So when someone is experiencing chronic pain, this is a very, very common path, which is fear-based movement, or lack of movement. So fear is going to drive more pain because the brain is responding to a perceived threat to the body's tissues. We call this a nocebo effect, which is being told an activity is dangerous, making you more likely to have pain with it. So it's a really classic feature of chronic pain and chronic musculoskeletal pain specifically. And it is actually the most successful variable in predicting which patients will develop chronic low back pain after an acute episode. So if they have this fear that they're not going to be able to do what they used to do, or they're never going to be able to go back to running or work or whatever it might be, this is typically what translates from that acute pain that we spoke about earlier into a chronic episode where there might have been some tissue damage initially, and then after that 3 to 6 month period, there's no tissue damage. However, their brain is still perceiving that there is pain. So the fear avoidance beliefs are prognostic for poor outcomes in subacute low back pain as well. And this is a good visual of the fear avoidance model of pain. So when there's an injury, there's going to be a experience that you have, right? Each and every one of us are going to have our unique lived experiences. If there is no fear, so you understand that you are going to get better, or your patient understands, I'm going to get better, then they're able to actually confront it. They might be able to manage it through rehabilitation or through movement, and they typically recover very, very well. If, however, they are fearful, they move into this fear avoidance, they can tend to catastrophically touch on their pain. So they might feel like this really negative thinking associated with it. They might feel like they're never going to get better. They have more and more pain, more avoidance. So they begin to shut down all activities. It might be the person that's going to just lay in bed and not do anything because they're too afraid to move. Of course, this is going to, for so many reasons, create disuse of the tissue. It's going to create depression, disability, and that cycle really just can continue to perpetuate. So we're thinking about how functional movement heals. It's through a variety of reasons. And first, we want to think about movement at its most basic form is going to improve blood flow, helps to deliver oxygen and nutrients to the tissue. It's going to help reduce inflammation because it's influence our lymphatic system. So to influence our lymphatic system, we need breath and we need movement. So once we begin to dampen that and we're not moving from injury and pain, then that definitely can contribute to exacerbating symptoms. And it's also going to activate our nervous system and help to reduce pain perception. This is where when we're thinking of movement and pain, it's going to have the greatest impact on the nervous system. So I want to talk about a low back pain case that I had. So John was 56 years old. He was a very, very successful entrepreneur, so true high achiever. And he was experiencing low back pain for years. He was a bodybuilder and he did some powerlifting. So he's lifted his whole life. But I used to see him in the gym and I knew that he was suffering from some pain. But what had happened was when he finally came to see me, he was so fearful of hurting his back. And again, chronic low back pain for probably 20 some years. He had been to chiropractors. He had been to all these rehabilitation practitioners. And he was so afraid to bend over. So when I did his first evaluation, I asked him to bend forward. He could not do that. And we did a very comprehensive treatment plan, which I'll talk about in just a moment. But we did movement therapy, focusing on breath, focusing on stability and sequencing and coordination. We worked on very specific mobility issues that he had. We also integrated a modified elimination diet to address some systemic inflammation that he seemed to be experiencing. And we're able to have a 90% reduction in pain in 6 weeks. He resumed everything that he was doing and even got back to a normal workout regime, meaning he was doing all of his fundamental movements, such as his squat and his deadlift, all of those things that you saw on that functional movement screen, but in real life movement patterns. So he was able to resume them, and were very targeted in terms of which mobility restrictions that he had. So in his assessment, I was able to identify he was extremely restricted in his thoracic spine and right shoulder. So he had had a previous injury. So because of that, that's going to create this asymmetrical force, asymmetrical load. It's going to influence his diaphragm position because we want that right hemidiaphragm sits higher than the left. But once you start to become over patterned, now we're creating these different forces along the spine. So I did have him do a very specific lumbar spine management. He was very painful with flexion, so forward bending. So I did have him really emphasize doing extension-based movements to be able to manage. So if he woke up in the morning, that he could do something like crocodile, lying on his stomach, breathing into that diaphragmatically, prop up to his elbows, and even some press-ups. Those are just super basic exercises, actually more to give him some confidence so that we can actually do all of the other corrective-based strategies. So we worked on things like hip hinging, so he could actually hinge from his hip properly and that he wasn't just bending from the spine all of the time. We worked on thoracic mobility, shoulder mobility. We worked on the stabilization pattern of how he could touch his toes. So teaching a posterior weight shift, so he was able to keep his mass centered while he was reaching down. We worked on foot to core sequencing to work on that fascial integration of his foot all the way up to his core. He had very specific toe mobility restrictions, so that was influencing how he was interacting with the ground every step he took. So with that, we were able to integrate some specific mobility work. Of course, we also, when we were working on foot to core sequencing, worked on sensory stimulation. So things like Noboso technology is a proprioceptive technology that stimulates those small nerves in the feet. So able to integrate a lot of these other tools, if you will, to be able to really get him to stabilize his body more efficiently and to be able to move more efficiently, transfer force, understand where his body is in space. And he did amazing. Also, was able to educate him on chronic pain, which no one had ever done before. And I think that that was extremely important. So I gave him some references. I had done a presentation. So educate him on acute pain versus chronic pain so that he could begin to have confidence in his body again. And I could give so many examples of this because that's what I've done and why I've gotten into functional medicine. And being able to blend all of it together is extremely important. So when we're thinking of someone that has chronic pain, I always like to look at it as what's happening from a mechanical standpoint. So are they not moving well? Are they not breathing well? But then also be able to look at it through our classic functional medicine approach is why are they dealing with these mitochondrial issues? So is that because they're not getting enough nutrients in? Is that because they're not digesting and absorbing? Is that because they have too much toxic exposure? Do they have leaky gut? Why is this happening? And that's where we can begin to blend all of it because ultimately we're still looking for the root cause. If we're thinking of movement and pain, we're thinking of root cause of that. So if someone has a shoulder injury, it's never the shoulder that's the problem. It's looking to see where else is that in the body. Is that the diaphragm? Is that the foot? Is that the neck? And the same thing with our classic functional medicine is we want to look for these underlying causes so we can really begin to allow someone to heal. And with chronic pain, we are thinking about helping them to rewire their brain, so neuroplasticity, because this central sensitization where the brain is detecting pain all the time and they can't dampen it, we want to use movement to help to retrain the brain, desensitizing these pain signals. With that said, we want to think about the different pain states that someone could have. So we can have a mobility-based pain category, we can have a stability-based category, and we can have an irritable pain state. And these are pain provocation states that can be a very helpful way in looking at movement and assessing it. And this can also help to navigate what someone needs. Do they need more stability? Do they need more mobility? Or do they need more desensitization because they're so irritable? Maybe this is neuropathic pain or so on. So these are some ways that we can begin to categorize them and also help to navigate it, in addition to having this very objective movement assessment to look at how are you moving or how is your patient moving, and how can we be very specific about how to begin to change movement for the better. In summary, when we're thinking about the management of musculoskeletal pain and chronic pain, physical exercise is extremely effective, it's cheap and it's a safe therapeutic option. So it does not produce any adverse effects unless you are going too fast too soon. So with chronic pain, we have to think about a graded approach. This is extremely important. It's slow and steady and purposeful. So just a little bit at a time so that you, or again, your patient, can begin to have confidence in your body. You can begin to be embodied and know what is too much, what's not enough, and be able to do that in a very systematic way. Because the moment that you do too much too soon, it can feed right into that fear avoidance path once again. In addition to what I just mentioned, physical exercise and optimal functional movement can influence all of our other modifiable lifestyle factors too, such as sleep and the way that we eat and our quality of life, our physical function, our emotional health. So there's so many downstream effects that it can influence. So I cannot say enough how important functional movement is and really doing it the right way in helping someone heal and recover from chronic pain. Thank you so much for joining today. If this was helpful, please make sure to subscribe to our YouTube channel for more videos like this on root cause medicine.
Welcome to Root the Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.